Hi, everyone. I'm going to shift gears a little bit and talk about an area I work in mental health. And really, one of the most exciting things I think in when we think of the field of medicine has actually been the tremendous paradigm shift that's happened. Like this doesn't happen very often when we think of clinical medicine, but it's happened in the sense of mental health. Um, Demonstrating just basically pioneering research in the early 90s. Emanating mainly from very low resource settings. So think of rural India or sub-Saharan Africa, demonstrating that you can actually treat and address mental health conditions in settings where there really were no psychiatrists, no psychologists. And this has now been demonstrated time and time again through, fast forward about 20, 25 years. We now have an enormous body of evidence, well over 120 some odd randomized controlled trials conducted in virtually every corner of the globe, demonstrating when you adapt psychosocial interventions, so these are brief psychological interventions when adapted to local context, culture, language, all of these different factors, they can actually achieve comparable outcomes to the specialist delivered mental health care, and even in some cases, superior outcomes. So even though we have this incredible amount of evidence, and it's really been a shift in the field demonstrating that this actually works, it's referred to as task sharing, we have very, very little uptake, virtually no uptake. And I use the analogy that if there was ever a cancer treatment or a cancer drug that had this level of evidence, but just such little uptake, people would be protesting in the streets, patients, families, providers. So my work is really how do we get these interventions into practice? What is the way to do this? So we know these task sharing models where you train community health workers, villagers, ordinary people, just regular people. We can train them, we can support them, but how do we do this at scale? So this is really the focus of my work. This is drawing from the accompaniment model. This is a model that pioneered by the late Paul Farmer. But essentially, how can we take someone, train them, give them these skills, but then support them, give them the ongoing mentorship and support to help them then support the next cohort of individuals. So think of this as sort of a sustainable pipeline for mental health providers. And really what's critical here is that mental health care is not easy. I don't want to simplify it. It's actually very hard work. You're working with people who are in crisis, who are suicidal, who are in really difficult circumstances in their life. It's hard to do. So, but it can be done, and with the right support can be done very well. And technology can play a role in helping us do this. So through a course of large studies, our team has led demonstrating we can use digital tools for training and also for supporting ongoing supervision, mentorship, building these skills and competencies to help these providers go out into their communities and effectively deliver these interventions. And these are brief psychosocial interventions, typically take 6 to 8 sessions, and it varies depending on the type of mental illness. Just to highlight, this is just giving sort of the pathway of the work that we've done so far with our team. Depression has been our main focus, mainly because it's just so prevalent. It's so common in virtually any place around the world. It's very recognizable. It's also very treatable. It's something that can be very, very, I don't want to say easy, but it can be readily treated with the right tools, the right support and right individuals. We've done this now in India. We've trained well over 2,000 community health workers using a digital platform. They're delivering this in rural India, now doing the exact same work in the United States, in rural Texas, also urban settings in Texas and in Massachusetts, training community health workers, members of congregations of churches, just ordinary community members, as well as social workers. I mean, really, you can think very broadly and creatively about who is in the right position to deliver these types of programs. We're also thinking about, adolescent emotional issues. So thinking of how do you build capacity of schools and the settings where adolescents are. So maybe the teacher is the frontline provider in that setting. Also severe mental illness. So thinking of even very, very, severe mental illnesses such as schizophrenia, which do require access to, a specialist, there's no question, but can also be supported through peer support. So we're working with how do we train peer support providers. Autism spectrum disorder is also a little different. That's actually the parents who can play a key role. How do you train and support parents in addressing these concerns? And then the list sort of keeps going on. I just also want to emphasize this is not a replacement for specialty care. It's actually a recognition that specialty care, there's just never going to be enough psychiatrists, psychologists, and the type of individuals that take years and years to train, but actually a way to get people to see those individuals who need it. So also training these frontline providers to recognize maybe this is someone who really does need to see a specialist. How can I help them get there and get the care they need? And just want to highlight that, I'm open to new ideas. I think there's a lot of room here. It's the way you think of who can deliver mental health care. We have to think of mental health care as something that happens outside the clinic. The vast majority of mental health issues can be taken care of in the community. So we have to think kind of creatively, who is at the best place to address these concerns.